Hey Renu, how are you?
I'm good, Declan. How are you?
I'm good. Have you had a nice Christmas?
I've had a lovely Christmas. It's not Christmas unless it's 30 degrees and warm and hot and there's cricket going on.
And it certainly is, because today is day 2 of the Boxing Day test here in Melbourne.
India versus Australia.
India versus Australia. So we got a special cricket/urology themed podcast to celebrate, don't we?
But it really is a fun time to be in Melbourne, isn't it? Because it's sporting season and cricket's just the start of it. When Christmas is over, none of us are disappointed because there's lots of sports to look forward to. And the tennis is coming up. The Australian Open will be starting soon.
And the Sydney Hobart race is on at the moment as well. So it's a fun time of the year to be in Australia.
So if you need a PSMA pet in Australia, it's a good time to get one.
I remember having a patient in the PSMA era about 6 or 7 years ago, a US physician who was tennis mad, had just been diagnosed with nasty prostate cancer in Michigan. And so I remember Todd Morgan said, so-and-so needs a PET scan. He's got high-risk prostate cancer. Do you think you could get him a PET scan? I said, sure. And tickets for the men's quarterfinals. So I was running a concierge service, which we did. Exactly right.
Yeah.
We've got a cricket-themed podcast, but to coincide with a great visitor and a great friend of ours from the olden days who's joining us here in Melbourne this week, Dr Mihir Desai from USC in California. Mihir, welcome to Melbourne.
Well, thank you. Great to be here.
And you've been here at the cricket, of course, all day today, day 1 and day 2. And
day 1 and day 2, a Boxing Day test match was always on the bucket list.
Yeah.
But I realized that, coming for an India game is probably not the best game to come. I would much rather come to a neutral game and not have my skin in the game.
Exactly. But hey, it's only day 2 and I'm sure we'll get to it. But and you're here with Daniel Moon, of course, Dan, friend of the podcast, advisor on the podcast. And
thanks, Dan.
And you took Mihir to the cricket yesterday.
It's been a pleasure to host Mihir and his family and friends. Here. We've been talking about it for a long time, coming onto the cricket in Australia.
No, absolutely. And Dan's been, a great liaison for me for cricket in Melbourne. He took me to the World Cup final in 2015. Organized a one-day course in kidney cancer 2 days before. And when he called me for that, he says, I'm going to make an offer you can't refuse. And of course not.
I remember that, Dan. I was with him that day as
This is when we were just starting off, Dick. We had to attract our guests, our big-name guests somehow.
Yeah.
Because the year before, we'd attracted your colleague from USC.
Yeah, Indy Gill.
Yes.
That's a story. Let's come to that story. So today we will be talking a bit about cricket. Please forgive us. But, if you're not a natural cricket lover, like I wasn't, an Irishman growing up in the UK, I've got to love cricket. It's a very entertaining thing to listen to. So there'll be cricket stuff interspersed in some great stories. But what we want to do, we've themed this one around minimally invasive surgery in urology, where we have been and where we're going to, because we want to tell a few stories about the olden days. Myself and Dan and Mihir pretty much go back almost 20 years in urology. And we were reminiscing recently about some of the stuff that was, really big news for us 15 or 20 years ago. You're laughing, Renu. You weren't quite at the same level 15 or 20 years ago, still in high school. So we want to pick Mihir's brains and reminisce a little bit about what it was like back in 2005, 6, 7, 8. Robot was coming, but there was a lot of other exciting stuff going on in minimally invasive urology. And part of your role at USC is a director of advanced robotics. So clearly you have, and you're working in a top center with Indy Gill and so on. So you must have some thoughts on where minimally invasive surgery is going. So that's what we're going to chat about on this special end of year GU cast. But before we do, Renu, we thought we would acknowledge our fantastic partners who've kind of enabled the podcast to grow as big as it's got in its end of its 5th season. We're going into our 6th year next year.
It's incredible. Yeah, we're about to celebrate our 5th birthday, and it wouldn't be possible to get this far without our incredible partners and especially the conference highlights that we've done over the course of the year. I mean, this year's been huge.
Yeah.
But, all the theme podcasts, all the conference highlights would not be possible without them.
And a few live events thrown in.
Yeah.
So we want to give a shout out to our gold partners, Johnson & Johnson, who've been with us since the very start, Mundi Pharma, who joined us this year, Bayer in China, who also do our conference highlights. And that's great fun, by the way. We were up there a couple of weeks ago and we're posting a couple of podcasts from Shanghai in the next few weeks in January. And Astellas, who just joined us recently this year as big players in oncology, because, of course, they've got interest in prostate and bladder cancer. Our silver
partners, we've got Bayer, MSD, Device Technologies, and, of course, Novartis.
And our bronze partners, Cipla, Ipsen, and Rigicon. There's a really good Rigicon episode coming about artificial urinary sphincter. Dan, we might talk to you about, there's another episode we're going to do with Rigicon on penile prosthesis as well, including some surgical education videos, so that'll be great. And finally, our partner level supporters, Icon and Shankar Siva, one of our advisors to the podcast, radiation oncologist, works with ICON, who are big providers of radiation and clinical oncology services here in Australia. So yeah, that's how we've been able to work from this nice studio and also to be out and about at conferences around the world.
And we've been able to
bring you
introduce a
these
few
episodes.
new little things this year, like our live events and the webinar style kind of events that we've put on, and they've been really exciting.
And merchandise. But today, the
Merchandise.
merchandise, I'm afraid for those of you watching, Dan's not wearing his normal GUcast stuff. So instead, Dan is proudly sporting a Cricket Australia top, Dan.
Yeah, I was expecting some Indian merch as well. I didn't see anything though. Backing up your team here, no? Didn't bring anything along?
Well, you guys have been friends for a long time and cricket buddies. Does this not cause any friction, Mihir? I mean, he's obviously an Australian supporter. I mean, you're deeply an Indian supporter. I can feel it.
No, he's a nice Australian and gets me in. So we can be
you'd
friends.
probably
And
say after this match that you're a nice Indian.
Now, you had another bit of merch I saw you walk in with there, Dan, a few minutes ago.
That's right. Just to follow the theme of one of the first Melbourne Stars teams, all signed. So
There you go.
the theme that's signed by also Shane Warne. Sadly, he's no longer with us, but he was well featured at the MCG, wasn't he?
Absolutely.
Health checks and tents all around the ground.
head checks and remembered fondly by all. So
So Dan, before we get into the minimum urology thing, there's a good Shane Warne story that involves Mihir from back in 2014 that we were talking about before we started recording the podcast. Do you want to take us back to that?
Yes, well, your colleague and Chief Indy Gill, who is at USC as well, at that time.
Also an Indian cricket lover.
Yes.
Lunatic,
And a great pioneer, of course, of surgery that we all aspire to replicate and achieve. We managed to attract him to a conference that we were running on bladder and kidney cancer.
Which was at the MCG, as I remember.
Yes, and this was how we could get him because he had never actually been into the ground. And so by tempting him with the offer of speaking at the MCG in the conference room there that we held, we managed to have him as the opening act, and it was and one of our major speakers, and it was fantastic, great meeting. But at the same time, coincidentally, a charity match was being run between a Merv Hughes team and a Shane Warne team, and knowing the cricket fan Indy was, we managed to get an introduction to Shane Warne down in the dressing rooms. But at that time, and this is where the minimal invasive surgery comes into it, I don't know if you're aware, Mihir, but we had never in Australia transmitted a live robotic case internationally before. And so one of the other great features of this event that we held was, for the first time ever, we were showing a robotic cystectomy, which had barely been done in Australia. A handful of cases and very few surgeons doing this at that time. This is bladder cancer surgery using robotics. And so we managed to, the technology has got to the point where we could transmit for the first time your live case from USC. We could watch you operate and talk to you in real time from the other side of the world. So you were operating in Los Angeles while your colleague Indy Gill was at the podium, except he wasn't at the podium because when we introduced you and you started operating, we had to say, Dec, you made the point that, I'm sorry, but Dr. Gill is down in the change rooms meeting Shane Warne. And suddenly you regretted the choice of staying rather than coming.
I was very jealous.
And we're for those of you on YouTube, we're showing you some of those images and video from that meeting. That was totally fantastic. It really was.
Oh, particularly in retrospect now, it was a great moment. And what a fantastic guy he was. Everyone that I've spoken to has ever met Shane Warne tells the same story, that he was exactly as you see. What you see is what you get. He's authentic, genuine, just a really good people person. And it was fantastic to have him as part of that meeting and that whole.
So Declan, it's a real pleasure, real privilege coming out to Melbourne again, this time getting to spend time at the Melbourne Cricket Ground, really Mecca, hanging out with you and Daniel, and then on top of all this, to meet Shane Warne. Shane Warne. Can you even believe it? He signed the thing. He's coming to LA. He's hoping we get to hang out a little bit. But the bottom line is, this guy is driven by excellence, and he is the best ever. And I think it's inspiring, and I just can't thank you enough. This was a real treat.
And I remember, so we'll go back a few months to the Cleveland era, but that was, I don't know, when did you move to USC?
2009.
Oh yeah, so this was about 4 years later. So, Dr. Gill is a busy person, of course, like yourself, but, in emailing guests like that to say, will you come all the way down to Australia? It wasn't always easy to get people's attention. And I know from experience before even emailing Indy that often you don't get a reply to the email. So Dan had sent him an email, a Dear Dr. Gill type of email, but to invite him to come to Australia to speak at this meeting. But rather than just say, Dear Dr. Gill, it's Dr. Daniel Moon here, blah, 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 he wrote it in completely cricket themes. And
well, he would get hundreds of emails like that. Could you speak here? Could you speak there? Could you speak there?
Exactly.
He said, where's Melbourne?
Yeah. So the title of the email, because I've got the reply here in front of me, which we posted on a blog on the BJUI, we'll put the link in the show notes. The title of the email was Opening the Batting at the MCG. So that got his attention. So we got a reply like 1 minute later from Dr. Gill. Dear Declan and Daniel, many thanks for your kind invite to open the batting at the MCG. My typical batting position is at 2 down when the sheen is off the ball a bit and the pacers and spinners start getting frisky. But in this instance, I would be delighted to open the batting, if for nothing else but to quell the frivolous and malicious whispers on the street that I may be a bit suspect against the late dipping in-swinger from a left-arm pacer from around the stumps. Quick as a flash, I can step into the ball and wrist flick it over leg slip like the Blazers, a la Sachin. It's time for me to show those loose-talking yokels where they can stuff their opinions. So, Captain, I'm all padded up and ready to roll. Just show me the gate that leads onto the ground from the visitors' dressing room. I'll take it from there.
So from that to then be able to get in the dressing rooms was a fantastic moment.
It was really great.
Very
it was
good.
fantastic. Anyway, so Dan and Mihir and Renu, I want to take us back to when I first met Mihir, which I think was about 2005 or 2006. So I was finishing my urology training at Guy's Hospital in London. And one of the Irish trainees who I knew very well was working in Cleveland, Nick Hegarty. And Nick was doing a fellowship in Cleveland, and Nick said, and we all knew Cleveland was very exciting, Cleveland Clinic. Indy Gill was there. He had Mihir there with him. Jihad Keok. There was a generation of very talented minimally invasive surgeons, and there was a lot going on, new techniques, etc. And meanwhile, Dan was in London doing your fellowship with Chris Eden. So at the time, robotic surgery was starting a bit, the first generation system, the standard system, but it wasn't at all clear that robotic surgery was going to be the future, because very many of all of us here were still doing a lot of laparoscopy, and we were working very hard doing lap nephrectomies, lap partial nephrectomies, lap prostatectomy. I was working with Declan Cahill, you were working with Chris Eden. These were really, really very, very talented, highly trained laparoscopic surgeons, including prostatectomy, 2005, 2006. And Cleveland was where a huge amount of it was happening. And among the things that were happening, Nick was saying, was single-port laparoscopy. So we knew Indy was doing very complex partials, which everyone was very interested in, but also single-port type technology. People were pushing the boundaries of laparoscopy. And I remember going over to spend a few days with you about that time, and Nick and Indy. So we wanted to take first of all, go back to that era of, do you remember what it was like back then, you know, when, you guys had all conquered lap nephrectomy, lap donor nephrectomy, you used to do a lot of in Cleveland at the time. And then all this single port stuff coming along.
Yeah, so it was an exciting time. I was part of, I remember the very first lap partial that Indy did in Cleveland. I was a fellow then, and I also remember the first lap prostate that he did. By the time, at least in Europe, the French had done a few hundred, but Indy had begun that then. And I was also part of the first laparoscopic cystectomy that we did with intracorporeal diversion. And now, fast forward to now, with a robotic platform, those things have become, I think, much more refined. I think our understanding of the operations has increased, but also it has allowed it to spread across all surgeons, even with lower volumes. You don't have to be an Indy Gill or such with that volume and that skill, and you can still give outstanding outcomes. But I think we're just basically touching the surface of where minimally invasive surgery can take us. I think in the current world of AI and image recognition, etc., I think the scope and boundaries of where it can take us are just outstanding.
And there's no doubt about it, Renu, the robots made it it's been an enabler. I think that's probably, as Mihir is saying, you don't have to be an Indy Gill to master these operations. It does give us the platform. Do you remember what it was like the start of, and what are your memories of the start of laparoscopic surgery? You're a few years
so
younger
when
than
I
us.
was training, it was really kind of, it was definitely mainly laparoscopic surgery. Robotic surgery was really just starting, and especially in the public hospitals where we train here in Australia, we didn't have access. So my real experience with robotics was during fellowship. And we're getting much better in Australia, I think, with more access to the robotic platforms in public hospitals. In the private hospitals, we've had a few years, but certainly that training aspect has improved significantly. And I think, Mihir, you've touched on this, is that learning curve to laparoscopic surgery is so much harder than for robotic surgery, and it really opens it up to so many more people to gain expertise in this.
So, can I ask a question though, along those lines? Sorry, but so Mihir, the conflict was at that time. You had a group of laparoscopic surgeons around the world that were very skilled, like yourself and Dr. Gill and the English surgeons were mentioned as well. You had this conflict because you had this choice of either pushing keyhole or laparoscopic surgery as far as you could, or switching across to robotics. And there were two schools of thought. There was the school of thought where you use robotics, it seems easier and you can do things a lot quicker and shorter learning curve. But there was the other school of thought, well, I'm this good with laparoscopy, I don't need the robot. At what point did your mind shift from trying to push to do as much as you can manually towards saying, okay, it's time to try the robot?
So to be very honest, it was more out of force. For prostatectomy, at least in the States, it became a thing that patients came in saying, hey, I want the robot. And so even if it's equal, that's what I want. And so once you started doing it, you realize that you definitely get a better, at least an aesthetic outcome. I mean, I don't know whether functionally it translates into the same outcomes, but you just feel you do a better operation. And then the more you use it, you feel that you can push the boundaries better. I mean, remember those days, we were still doing a lot of Gleason 6 cancers, organ confined. I mean, the spectrum of disease that we treat currently has changed. And I think that's where, again, robotics has really made a difference.
It definitely has. But if I go back then to laparoscopy in that era, and people were getting good at doing lap nephrectomies, lap kidneys, and so on. But you were interested in the single port stuff. So this is the idea. I mean, laparoscopy was really a little bit difficult.
Yeah. And so
but at least you had multiple ports. But then, putting all the instruments through one port. Now, younger viewers and listeners will think, well, that's what the single port robot does. Yeah, but remember, if you only have straight instruments and you're trying to put them all through one port, it was very, very difficult. Do you remember that era?
I did. So we had, I got mentoring from our colleague Jeff Cadeto in Dallas, and a very skilled laparoscopic surgeon again, who would have had the same dilemma as to at what point he transitions to robotics, and again, may well be because of market demand. But we try to push ourselves to do things better and better, and suddenly you're making what is already complex surgery even more difficult for ourselves by adding another level of difficulty, which is doing it through one port. And so then
with really basic instruments,
there were ways of trying to do that where we crossed instruments and had articulating instruments that went in so that your right hand was your left hand, and you had to counterintuitively work that out as you operated. And operating on kidneys where you're dealing with major vessels, if there's a problem, suddenly your ability to salvage that was limited, very limited. So it was, walking a tightrope with much less of a safety net, and we were just making things more and more difficult for ourselves, weren't we? I went to Dallas, and Jeff was unbelievable at it, but no one is going to be doing single port laparoscopy now.
So I'll go back to when I first visited Cleveland, then I'll tell you a story about going into the operating room. I spent a couple of days with Mihir and co, and they used to do a lot of donor nephrectomies, as I recall, and I was in the operating room with Mihir, and he was doing a single port lap nephrectomy. And again, it was a single port, but it was these, instruments, prototype instruments. They cross over like this and then bend. That's the only way you could operate with them. And it was very difficult. And even watching master surgeons like this, I was thinking, wow, that is very difficult. And meanwhile, in the parallel room next door, they were getting set up for a lap donor nephrectomy. That was going to be on Dr. Desai's list. He had to pop next door when this case was finished and do that. And they were getting the patient ready, and it was going to be a multi-port, like a normal lap donor. The single port case was coming to an end, and the fellow was coming in from next door saying, no, we need to wait for Dr. Desai to come in because he's very particular about where the ports go for his lap donor nephrectomy. You need to have this one here and draw out the thing and that. And so they managed to get over to Dr. Desai, who was finishing this very difficult single port thing very successfully. And he said, oh, Dr. Desai, we just need you. We're just waiting for you to come in so we can, put the ports as you like them. He said, I don't care where the ports go, as long as there's quite a few of them and they're roughly in the area of the kidney, please. and that's how it felt to me, Dan. I must say, at the time, watching a very experienced surgeon do this. They,
Yes.
And they
Why
said,
are you making
just
it so
wouldn't it be nice if I had more than one port?
On the other hand, I did one. We did the first one ever in Australia.
Yeah, I remember
It
this.
went
You
very
did-
well,
yeah.
and that was it.
That was it. You did the first
the
case in
first and
Australia,
only
went on the radio, and never did
yeah,
another one.
great
So what I used to tell my trainees then was the best part about single port surgery is when you do the next multi-port case to realize how much nice it is. It also reminds me of my best moment skiing is not when I'm actually skiing. When I take my ski boots out and put my sneakers in and I feel the nice soft shoe, that's the best part. So that's what happened with single port laparoscopy. So just talking a little bit about that theme, I think, we were very excited then. I think there was a little bit of an internal bravado that, hey, we can do it through a tiny little cosmetic incision. There is now a kind of a resurgence with the single port robot being available. But I still feel, though, that, at the end of the day, as Dan mentioned, we do a lot of cancer cases, high-risk prostates now, complex partials now, and you need all the tools you can get. And to me, what has made the biggest difference in robotics is the wrist. The endo wrist is what gives you that dexterity. And you've kind of taken that back with a single port robot, which gives you a kind of an elbow. They call it a wrist, but it's really an elbow. So it gives you triangulation that you didn't have with standard single port laparoscopy, but it takes away the wrist. So it almost reminds me of I'm doing a multi-port laparoscopy all over again. And I think we've evolved from that. So now in my mind, when I talk to Intuitive and I say, look, if you want me to do single port robotics, give me a single port robot that has a true wrist. Then that'll change the equation. But if you're giving me an elbow, I did laparoscopic, and they come back, oh, if you hold the needle like this and at this angle. I said, that's what we used to do when we did lap prostates. The idea with the robot is I don't have to think about what angle. The wrist allows me to compensate for that. So that's what we need. So I think we owe it to the field to demand from industry that we're not going to just use any tool you give us. It has to be a tool that makes sense. And I think having more of these players in the market now, the Medtronic robot is in, there are a few from China, and they're doing things like telesurgery, etc. I think that's where I think the pressure would come in. And we did learn a bit of a lesson from single port laparoscopy that, yes, things can be done, but we want to make sure that they're done with the same finesse, with the same efficiency, and for the patients that we deal with currently.
Yeah. Well
Very well said, yeah.
It's so much of it is marketing. It's like what you said at the very start, Mihir. In Cleveland, you had all these talented laparoscopic surgeons, and I remember you had one of the very first robots that was manufactured, like number 4 or 5, and it was sitting there. Jihad was using it a bit, but it was actually almost market pressure that said, well, patients want robotic surgery regardless of, I can just do just as good a job. The single port thing is a bit like that in the US. Every time you come out of an airport, you just see the single port on a big billboard outside a hospital. And it may not be the right thing. It's wise words, yeah.
Also, the more difficult you make an operation, the less likely it's going to be taken up by surgeons. That's what we found out with laparoscopic prostatectomy or laparoscopic cystectomy. You make it such that only a very small number of highly skilled and highly trained surgeons can do it, which means it's never going to take off because we need access for everyone for these operations, for minimally invasive surgery. That's why robotics has been such a leveler. We can really now offer it around the world. You don't have to have been to these very subspecialized places and done thousands before you're any good at it.
Absolutely.
But Mihir, I think, as technology advances and we get more and more of these advances within the field, like you mentioned before, there is a sense of bravado in doing single port surgery. But can I ask you, what is your opinion on where it is really useful? What do you think are the true indications for single port surgery? Are there specific cases in which you would consider that over the traditional methods, or is it purely for patient cosmetic benefit? What are your thoughts?
So, I really do feel that you could use it for kind of benign reconstructive cases. I think that's a good way. I'm very excited about endoluminal applications, and the currently designed single port system is a rigid system, and it may not be as relevant, but there are now flexible robotic tools. Jamie Landman and I did the first in man trial on a Johnson & Johnson robot, previously Oris, to do stones, but that's a robot that can be absolutely modified to do endoluminal bladder on block resections or things of that nature. I think that's where the field is exciting. I'm just not sure what the role of a purely single port device. Now, if you have a wrist and if you can say it gives you the same dexterity that a multi-port robotic system gives you, then anything you can do multi-port, you can do through a single port system also. But currently we're not there yet. And so that's where I think the next level of engineering needs to happen with single port.
And cost renew is the other thing, because these are already expensive systems, but single port, certainly here in Australia, the capital investment will be more and the per case will be more. So you really have to have some sort of rational sort of approach to say this will be of benefit. Someone's going to have to pay for it, patient or insurance company or public hospital. So.
And for things like a radical nephrectomy. I mean, I love doing a radical nephrectomy. It's still one of my favorite operations to do. Pure lap.
That probably doesn't happen in the US anymore. People have renewed. Do people get trained to do laparonephrectomies?
Very little. So the laparoscopic training that our trainees get are when they assist complex robotic surgery. So like when you're assisting a robotic cystectomy, that's where I actually insist that at least the junior level residents do the on bedside training, not the dedicated PAs that we have, because that's where you're using both your hands. You're suctioning, you're retracting, you're clipping, you're stapling. So you get a little bit of your laparoscopic training. But it's a great question. I mean, from an outcome standpoint, there is no reason why you would need to use a robot unless you had a complex cable thrombus, etc. But for a straightforward nephrectomy, you should be able to do it lap. But it's. I like to give an analogy. If I have a Toyota Corolla and if I have a Mercedes, and people would say, you know what, if you're doing 500-mile road trip, you should take the Mercedes. If you're going around the corner to get your gallon of milk, you should probably take your Toyota. But once you get used to driving the Mercedes, you don't want to sit in the Toyota. So that's why now I've gotten lazy. I don't want to hold the camera.
You want the seat warmers
I don't
when you go around.
My deltoids are now not in shape, and so I love to be able to sit on the console and do my case.
I remember when I was doing my fellowship, we'd be getting on the console. It's all very exciting, and then you realise actually the surgery happened with the attending scrubbed in bedside. We were just very expensive retractors on the robot console. It's amazing that skill to still be able to go back to the bedside and do a case laparoscopically. And I think that's what you find in a lot of very experienced.
That's why I was looking forward to chatting to Mihir and Dan about this over this few days. Is that nostalgia for the 2000s when all this was happening, and the robot was coming. But still, most of the excitement was in laparoscopy for us, and wasn't it, Dan? I mean, you went to Europe to do a laparoscopic fellowship.
Fellowship.
Superbly talented.
There was really nothing. Laparoscopic surgery was barely taking off in Melbourne at that time, and
actually, I'm just telling you. Did you write an article with Chris Eden in the BJUI where you described the robot as being an expensive sewing machine?
It rings a bell. So this was, again, one of these conflicts I brought up with Mihir about, the challenges. We had to try to predict the future. Who are we going to back here? We're going to back ourselves to do all this training. I can do this. I know how to do this. Who needs a robot? But suddenly you realise, wait a sec, if they can do that with a robot, imagine what we can do with this training. And that was the mindset shift.
I remember at Guy's it was the same, because in Theatre 7 was Declan Cahill, trained at Montsouris, extraperitoneal prostatectomy, fabulous surgeon, and I wanted to work with him and work hard like him. I built a box at home, spent hours laparoscopic training. Next door in Theatre 8, Procar got a robot, 2004, a standard system 3-arm robot, and that was exciting, and there was a lot of buzz around it, but it was transperitoneal. It took a lot longer to do the surgery. Declan's patients went home the next day. Back then the robot stayed 2 days in hospital or whatever. And there was a kind of an elitism. It was like top order cricket as well. It was like what's his name, Constas, showing off all his trick shots. The lap surgeons who were really, really well trained could pull off any maneuver, every difficult stitch. You just had to train hard and have the right suture, right hand, backhand, left hand, backhand. You set it up. Whereas the robot compensated for that. You could use your left hand and right hand, and the angles and so on.
But where you're taking it now with the partials, with the cable thrombus, with the complex cystectomies, intracorporeal diversion, this stuff is not for laparoscopy. This is for wristed instruments, 3D vision.
But in the last few minutes, Dan, what we thought we might try and pick Mihir's brains about was, as in his role as director of advanced robotics and so on, and we can talk about transperitoneal surgery, but also endoluminal, as you said. So where will these conversations be for youngsters out there listening to this podcast for in 20 years' time, they'll say, remember back in the days of 2024, and we were excited about single-port, but now what we have is. So, give us your future gazing thoughts.
Well, if I had to predict the future, I think we may not see surgery as is done now. I mean, the excitement is, we're getting better at understanding the disease. We're getting better at knowing that we were operating on too many prostate cancers and we don't need to. I think for cystectomy also, for example, now it's an exciting phase where finally we have systemic therapies that do such a good job that you may not need to get to a cystectomy after a complete response. I'm very excited about some of these trials that are ongoing. So I think the goal should be to not have to do major surgery that we are currently doing. And so maintaining quality of life, and yet, we've been blessed in urology to have, other than urothelial and some other kind of bad actors, pretty much we deal with, friendlier cancers. And so, it's up to us to see how best we can manage these without being too radical. I think that's where the excitement is. And so, yes, I think, surgical tools will continue to evolve, but I think as surgeons, we need to really see which is that subset of patient that is benefit from radical surgery. And I'm very excited about, the focal therapies and innovations in various systemic therapies that will maybe help make these obsolete.
And does artificial intelligence fit into that?
It absolutely does. And I think, getting, better predictive algorithms, et cetera, is, I think, very important. What we are excited about with artificial intelligence is also in the surgical evaluation and training. I think it's a very difficult and slippery slope in ranking or rating. You can do that for almost any other thing, but surgically, I think we haven't done a very good job in kind of giving a good scorecard and tools that can help people improve at various stages of their career. And I think that's where AI would come into.
It's a happy irony, isn't it? As we get these amazing tools where really there's a move to do less surgery.
Do less.
It's incredible.
Very good.
Wow.
I really enjoyed that.
Back to the cricket?
Made the best team win.
Back to the cricket. So just to wrap up, so it's day 2
early
now.
days.
It's the 27th of December, Boxing Day test. So, the MCG just down the road here, 10 minutes away. There were 87 or 88,000 people there yesterday watching the cricket all day. 80-odd thousand today. So it's day 2. It's finally poised. Dan, what's your take on it? Australia have posted a big total for.
Yeah, there'll have to be some strong batting tomorrow morning, I think, Mihir.
Yeah, a few late wickets this evening.
Absolutely. Short of a Rishabh Pant 100, then we're back to game on. Otherwise, it's going to be a long road for the Indians. They're now in the single-port laparoscopy mode.
Love it.
Love it. Totally
Very
fantastic.
good.
Well, Mihir, thanks very much for dropping in. And we're going to take you out for a nice dinner now in Melbourne and then more cricket tomorrow.
Always. And if there's ever another opportunity of coming down here,
And opening the batting at the
Open
MCG,
batting,
yes.
I can come down as a night watchman. That's fine. But there'll always be a
Clean the change rooms. Yep, that's true.
Fantastic.
All right,
There you
very
go,
good.
Renu. Did you enjoy that?
I did, of course.
That's great. So that's the end of 2024 for us, end of season
is,
5
yeah.
on GU Cast. Thanks
Looking
very
forward
much
to a great year ahead. I think it'll be a good one.
Clink. We have actually empty champagne glasses we were drinking earlier. So here we should do a little clink. 'cause
We
I know
should.
people like when we clink. So, there you go. There'll be a clink on the audio for those of you in. And we will be back in 2025 early. We've got a few episodes in the can, as they say already. You were in Singapore at ESMO
Asia. Yep,
so
great
we got
meeting.
A few interviews from there. I was
absolutely.
in Shanghai
That's
at
right, big
Ding
meeting.
Wanye's meeting with Bayer. So we've got 2 or 3 podcasts coming from there with some
absolutely.
international guests.
Lots of
and
great meetings
We still have
coming
one in
up.
the can from when Kim Chi and Carmen Mir were here. So
Oh, yes. Yeah. That was our live event.
yeah, live event. So we got some stuff coming for your holiday period if you're here in Australia, or for the winter, those dark winter evenings in Europe. And thanks very much to everyone for all your support again this year. And we'll be back with another podcast.
And
very soon.
Happy New Year
Happy
from
New Year.
GU Cast.
Cheers. Thanks, Mihir. Thanks, Dan.
thank you.